So, coming to speak to us today is none other than Dr. Charles Raming, consultant neurologist. Let me give you a little information about Dr. Raming, many of which I haven't even known. So, we're going on an educational journey together. Dr. Raming graduated from the University of the West Indies Medical School in 1989. He worked in the Department of Surgery for 3 years. Then he switched to medicine and he did his residency in neurology at Howard University from 1993 to 1997, where he was appointed chief resident and named Resident of the Year. He then pursued a fellowship in epilepsy and EEG at the University of Wisconsin-Madison. He then completed another fellowship in EFG, nerve and muscle disorders and movement disorders at the North Carolina Baptist Hospital at Wake Forest University. He is a board certified by the American Board of Neurology and Psychiatry, as well as by the American Board of Electrodiagnostic Medicine. He returned home to Nassau in 1999 and has since been working as a consultant neurologist at PMH and Doctors Hospital and is an associate lecturer and examiner for UWI. He is married with 2 children and 1 granddaughter. Please welcome Dr. Raming.
Thank you very much. Thank you very much. It was a pleasure to give you all this presentation this morning as it's Parkinson Month. So I'll just begin. So get these. So Parkinson's disease was first described by James Parkinson in 1817, and it was described as the shaking palsy. And it was not until 1959 when Horny Kivix discovered that it was actually a dopamine deficiency that was causing the disorder. Since then, we have discovered that it had both genetic and environmental etiologies. And it's a combination of the genetic predisposition and environmental interplay with toxins in the environment that is now considered the cause of Parkinson's disease. It is been isolated to the alpha-synuclein gene, as well as to the PARC gene, and also the LRRK gene as well. And the problem is that it is a disorder of protein handling. So it's the alpha-synuclein protein that is being mishandled and misfolded, and it causes the accumulation of malfunctioning or damaged mitochondria. And these mitochondria cannot be broken down in the cell, and so they will cause release of oxidative species that cause cell damage. There are 6 cardinal features of the disease. The first is tremor at rest. The next is rigidity, bradykinesia and hypokinesia, a flexed posture, loss of postural reflexes, which you test by having the patient stand up and then you pull them back to see how much steps they would take to fall, and a freezing phenomena, which typically occurs in narrowed passageways or when they're turning. You need 2 features with either tremor or bradykinesia to make the diagnosis. Importantly, tremor is not present in all patients. About 30% of patients with Parkinson's disease would not even have a tremor. So if you have the bradykinesia and the loss of postural reflexes, then you could still make the diagnosis. So here's an example. I'll play these videos because it wouldn't play on this one a little later. And so this is an example of the flexed posture. The knees are flexed, the hips are flexed, the elbows are flexed, and the hand is a striatal hand with the fingers bent at the MP joint and straightened and extended after that, and ulnar deviated. So what I do in my practice, first thing I do is I have the patient sit down and fold their arms, and I count how much time it takes for them to get out the chair. So this is indication how much bradykinesia and that they have. And so persons who are well controlled, they bounce right up. They on one shot they get up, or they get up more slowly, and then sometimes they take 2, 3, 4, 5, 6 times before they get up, or they never can get up with their arms folded, so they use the chair arms to get up. So Parkinsonism is a broad category of all the symptoms that look like Parkinson's disease. So there's idiopathic, there's symptomatic, Parkinson plus syndrome, and other degenerative diseases. So we'll just be talking today on idiopathic Parkinson's disease. So the prevalence is about 360 per 100,000 persons. So with our population about 400,000, we should have well over 1,200 persons. The incidence is 18 per 100,000 per year, and has a male predominance, a female of 3 to 2. There's a steep increase in incidence after the age of 60, and has a higher incidence in industrialized countries like United States, and lower incidence in China and Africa. There's probably some environmental overplay that's causing that, which is since needed to be elucidated. The onset is gradual, and the most common presentation is tremor at rest in one hand. It is asymmetric disease. If you see the symptoms are symmetrical, you have to really question the diagnosis of Parkinson's disease. So it always starts with one side being worse than the other. If you ask the person to walk, there is decreased arm swing, and then that also can bring out the tremor in the affected hand. Oftentimes, they first present with shoulder pain, because what happens is that they have decreased swing off that shoulder. It's almost like they have a frozen shoulder because it's not moving because of the bradykinesia. You also get bradykinesia and rigidity in the contralateral hand, and this could be brought out by asking the patient to move the affected hand, and then you get these other symptoms of Parkinson's disease more prominently expressed in the contralateral hand. There's reduced facial expression, what is called a mask-like face, and there are, of course, difficulty getting out of chairs, getting out of the bed, difficulty turning in bed. The gait and balance problems progressively progress until you get to the point that they start to have falls. They have freezing and motor blocks, which cause the falling. So imagine they're walking along and they have some momentum, and all of a sudden their legs freeze and they can't move. And so they topple right over like a tree. This freezing usually begins with gait initiation, but also can manifest on turning and traversing narrow or crowded environments. So typically they freeze in the doorways or in the corridors. Bulbar functions deteriorate also, and they cause impaired communication and nutrition. So they have a lot of hypophonia. You could barely hear what they're saying. They have a lot of drooling. They have difficulty swallowing later on in the disease. So this is just how they are flexed posture. So they have bradykinesia, freezing, and loss of postural reflexes are the most disabling. And this is what causes the patients to eventually become wheelchair bound and eventually bed bound. If you look at the tremor, it's a 4 to 5 hertz tremor. It's a pill rolling tremor where the fingers are rubbing together against each other. And this tremor disappears with movement. So if you ask them to reach for something, the tremor goes away, unlike the central tremor, which would then be manifested. The ones in Parkinson's disease goes away with movement. There could be also tremor of the lips and chin and tongue, especially if you ask them to show their teeth. If you ask them to show their teeth, all of a sudden they have this tremor of the lips and the chin, and if they stick out the tongue, the tremor of the tongue. The tremor typically increases with walking and with stress. So if you ask them to walk, that hand tremor increases. If they are nervous, the hand tremor increases. They also could have tremor of the feet as well. Because of the superimposed tremor on the rigidity, they get what's called a cogwheel rigidity. And so you could bring this out by asking them to open and close the contralateral hand. And so that would bring out the cogwheel rigidity. This rigidity increases with voluntary movement of another extremity. And when they are standing, they have the elbows, hips, and knees flexed. And they have this what's called a striatal hand, which is an ulnar deviation of the hand. And of course, mass space. When they're sitting, they tend to lean to one side. So, and if they're sitting on a couch, they could either start leaning back or to one side. So they cannot keep their balance even while sitting. They have decreased blinking. They sit motionlessly. They do not make the usual movements that normal people make by shifting from time to time in their seats. They will sit just like a statue. They have hypophonia, and sometimes this is so severe that you can hardly hear what they're saying. This is combined with a monotonous speech and dysarthria, and also is some of them speak very fast and very softly, so you would hardly understand. If you get them to write, they have micrographia, and they draw much smaller drawings. If you're trying to make the intersecting pentagons in a mini mental status examination, you'll find that they could draw that much smaller as well. They have a shortened stride, shuffling gait, and of course the decreased arms swings, difficulty getting out of chairs, I mentioned turning in bed, and they have a lot of drooling later on in the disease, and this is due to decreased spontaneous swallowing. This also affects their nutrition because they tend to hold the food in their mouth for long periods of time before they swallow it as well. They are complaining of fatigue, loss of energy. When they go to sit down, their whole body just drops into the chair. So that's called sitting in block. When they are turning, they turn with little small mincing steps. And so they're turning in block as well. There's also a phenomena where some of them, when they start to walk, they just go fast and fast and fast, and they cannot stop until they crash into onto the wall or some object. So this is the stoop posture. I'll show the videos hopefully later when they could play. The freezing and postural instability leads to falls and hip fractures later on in the disease. Parkinson's disease itself makes about 80% of all the cases of Parkinsonism. Now, besides the motor manifestation, there are cognitive and behavioral changes as well. They have decreased attention and concentration that can wane. They have cognitive decline. They have diminished working memory, planning, and organization. They have decreased speed of thinking, what's called bradyphrenia. they can get the answer out, but it takes them much longer to figure out the problem. This causes a lot of indecision because they can't think fast anymore. And about 20% of them also develop concomitant Alzheimer's disease. But about 50% of them have this bradyphrenia and mild cognitive impairment, even though it's not Alzheimer's disease. And they have depression and anxiety in about 40%. They have disordered and fragmented sleep, and they have problems falling asleep. Often that time is due to the resting tremor, because it'd be so disturbing that the tremor doesn't allow them to get to sleep. They have problem maintaining them sleep, because what happens is that the Cinemet effect runs out in the middle of the night. It only lasts about 3 to 4 hours, the Cinemet dose. And so they end up frozen in the bed and they cannot turn. And so they get uncomfortable, and so that wakes them out of sleep. They also suffer from restless leg syndrome, periodic leg movement of sleep, and REM sleep behavioral disorder often precedes the diagnosis of the Parkinson disease. So this is when they start to act out their dreams. They start to kick and punch their spouse in the bed, unknowingly, and screaming out in their sleep and stuff like that. They have vivid dreams and nightmares, and sometimes this could be accentuated by the medications that you're giving them as well. Parkinson's disease also causes them to be very sleepy in the day, and a lot of the medications also exacerbate this. The Cinemet causes them to be sleepy, and the dopamine agonist makes them more sleepy. So this gives them a problem sleeping at the wheel. Most of my patients who are well on with their Parkinson's disease, their biggest problem is that after they take their morning dose, they go right off to sleep again. And so they wake up sometime in the middle of the day. So they really don't start to do anything until like early afternoon, because after their first dose of their medications after breakfast, they're gone to sleep. They have a lot of autonomic disturbance. They have cool skin. Constipation is a very common problem, and this oftentimes predates the onset of the Parkinson's disease clinical features. I'll get to why this is important later. It's all tied up with the gut. I'll explain that later. There are postprandial bloating. Everything feels too full. They have inadequate bladder emptying, which means to cause frequency at night and urgency and urgent continence. The males develop erectile dysfunction, and Parkinson's disease itself causes orthostatic hypotension. And this is unfortunately compounded by the Cinemet and the dopamine agonists, which also cause orthostatic hypotension. And this itself could contribute to their falling. Okay, so you have them having the bradykinesia and freezing, and then on top of that, orthostatic hypotension. So I always check their blood pressure lying and standing to see if they have this orthostatic hypotension, because sometimes when you correct this, that will cause the patient to have a much better quality of life. They're not falling anymore. They also have seborrheic dermatitis because of all the increased oils in the skin. If you start to have on examination like an extensor plantar reflex, then you have what's called Parkinson plus syndrome. And other features that you would have with Parkinson's disease itself is the glabella tap. If you tap over the glabella, then they would start to blink. Normally, this would be habituated after the 10th tap. But Parkinson's disease patient, they continue to blink on way well after 10 taps on the glabella. The snout reflex is also present. That's when you tap over the upper lip, and they would start to protrude their lips like a snout reflex. The palmar mental reflex is when you take your patella hammer or pen and you scratch across the palm, and that causes the mentalis muscle in the cheek, in the chin here to contract. So that's the palmar mental reflex. These are signs of cortical release reflexes that you can see in Parkinson's disease. The Horn and Yahr stages of Parkinson's disease, there are 5 stages. There's stage 1 is the unilateral involvement only. So this is when they first present with just one limb with the tremor or rigidity. And they have little or no functional impairment, they just have a little tremor. Stage 2 is when they have a bilateral involvement, so that both hands are shaking now, but they don't have any balance problems. Stage 3 is the first signs of balance issues, but it's just mild to moderate. Stage 4 is when you have a fully developed, fully disabling disease, but the patient is still able to walk and stand unassisted. But if you pull them back, or they're making about 4 or 5 steps before they fall. And stage 5, they can no longer walk without assistance. So they're either, no matter what you do, and they are either confined to the bed or wheelchair unless unaided. Parkinson's disease is a clinical diagnosis with an accuracy of about 90%. There is no real test that you could do, so I could order a blood test and I can confirm that this is Parkinson's disease, though you can do some testing like a DAT scan or spectral images looking for both dopamine uptake, and you can get a sort of an idea that this is what the disease is, but there's no test that we could use that is that will say that this is Parkinson's disease. In the etiology, it was noticed back in the 60s that MPTP, which is methylphenyl tetrahydropyridine, it was a contamination that they used to cut the heroin with. Persons who had that, who had taken that intravenously, they developed Parkinson's disease. And so this was a big revelation, because the scientists now say, well, what does this do? And so it was a toxin to the pigmented dopaminergic neurons in the substantia nigra. So it causes Parkinson's disease, which is irreversible in these young drug addicts. Other causes that have been discovered are pesticides like paraquat, rutenone, which is used as a weed killer, and they were able to reproduce Parkinson's disease in lab animals as well using this. So the first thing I tell my patients is that, do you use insecticide? And the overwhelming majority of them said they spray in for roaches and mosquitoes almost every day with that Baygon or Raid. And so the first thing you tell them, get rid of that out your house. Do not spray that in your house at all. Or other persons would have people come in every month or every 3 months to spray around that baseboard in their house, which is a very dangerous thing to do, because both Parkinson's disease and Alzheimer's disease have been associated with pesticide use. And they found pesticide residue in the brains of Alzheimer's patients as well. So any of you doing those practices, please cease and desist. It's interesting that Parkinson's disease is much more prevalent in farm workers. People out in the farm getting all the fresh air will wonder why in the world they should get Parkinson's disease rather than the city slickers. The problem is they're out on the farm, they're using all kinds of pesticides on the crops. And they having these planes sometimes come in and spray insecticides all over the fields. And where are they living? Right in the farmhouse, breathing all that in. So this pesticide exposure is a great risk factor for developing Parkinson's disease. It's also been found in welders. Welders, they use a lot of manganese in the welding compounds. And this manganese vapor is breathed by the workers, and they end up with Parkinson's disease at the end of the day. Now, there are genetic causes as well, and there is increased incidence in twins if the onset is less than 45 years old. But truly inherited Parkinson's disease only happens in about 5% of the cases. The rest is sporadic. But there is a genetic predisposition that has to be interplayed with some environmental exposure. And the genetic ones, the onset is before 45 years, and that one is associated with the alpha-synuclein gene. So when you look at what really causes decreased incidence of Parkinson's disease, if you have a diet high in antioxidant-rich foods, if you are a coffee drinker, and interestingly enough, if you are a cigarette smoker, you are less likely to get Parkinson's disease compared to people who don't do these things. I wouldn't advise you to start smoking, though. You will die of something else much earlier. The pathophysiology of Parkinson's disease, there's the decreased dopaminergic transmission in the basal ganglia. So basically, there's a degeneration of the neuromelanin-containing neurons in the pars compacta of the substantia nigra in the midbrain. So drug-induced Parkinsonism is caused by the blockage of these dopamine receptors or depletion of the dopamine stores. Decreased dopaminergic activity in the striatum leads to disinhibition of the subthalamic nucleus and the medial globus pallidus, and this causes all the bradykinesia and slowing down and freezing. When you look at the pathology, there's a normal person here, and you can see the substantia nigra there is nice and dark, is a black substance. That's what the substantia nigra means. And over in the person with Parkinson's disease, you see is no longer, there's no blackness here. The blackness is all gone. The substantia nigra, all the pigmented neurons are gone in this person with autopsy with Parkinson's disease. When you look at the histopathology under the microscope, you find these eosinophilic inclusion called Lewy bodies, and they are filled of the alpha-synuclein misfolded proteins. The substantia nigra loses about 60% of these pigmented dopaminergic neurons before symptoms appear. The onset is insidious, is unilateral onset, then becomes bilateral, and they have decreased attention span. They have problems with visuospatial impairment. So they have problems judging how fast that car is coming. And so, so they have perception impairments as well. And as I mentioned before, because of the bradyphrenia, they become indecisive. Now, when you look at under the microscope, you see these eosinophilic inclusion bodies. So these are the Lewy bodies. These are not only scattered in the basal ganglia, but also be scattered throughout the brain. When these are very much, a lot of them are in the brain to produce Lewy body dementia, which has some features of Parkinson's disease, but also have dementia with profound visual hallucinations very early in disease. So if you find somebody who looks like they're Parkinson's disease and they're also demented, and you give them a little bit of cinnamon and all of a sudden they have all kinds of visual hallucinations with the lowest dose, you have to consider that you're dealing with Lewy body dementia. This is the silver stain of the same Lewy bodies down here as well. So the treatment, the levodopa has been the gold standard since in 1960s when it was discovered that dopamine was the deficiency was the problem. You have to combine it with an aromatic amino acid decarboxylase inhibitor. In the United States, they use carbidopa, and this causes this is to inhibit the peripheral conversion of L-dopa to dopamine. Because if you don't do that, the patient would have severe nausea and vomiting, and because it's the dopamine would trigger the chemoreceptor trigger zone in the base of the fourth ventricle, in the area postrema. And so if you don't put in the carbidopa, they get very nauseous. And so Cinemet comes in different strengths of the carbidopa. You have 10 over the 100 and 25 over 100. I didn't bother with the 10 over 100. I just used 25 over 100. The 25 is the carbidopa moiety, and the 100 is the levodopa portion. But you need to have the two of them combined, else it will become intolerable for the patient. It also can cause cardiac arrhythmias if you have so much of that peripheral conversion. This becomes a problem when you try to increase the dose of the medicine to switch to the 25 over 250 dosing. Sometimes when you switch there, then the patients start to get nauseous because they're not getting enough of the carbidopa. So to counteract that, instead of giving them 125 over 250, I'll give them 2 of the 25 over 100, which will have a similar effect. Even if you start treating your Parkinson patients with another agent like a dopamine agonist, you would still have to end up giving them the Cinemet or levodopa, because those agents would, at the end, as the disease progresses, they are not as effective as the levodopa in getting a response. So you could start off with the dopamine D2 agonist. We don't really use bromocriptine, the pergolide, and the glyceride, because these can cause retroperitoneal fibrosis with long-term use. The ones that we typically have here is the ropinirole or Requip and pramipexole. And so there is another agent, rotogotine, which we don't have here. And so, we don't have the apomorphine, which is the short-acting versions. This is very useful when you have these off phenomena where the patient start to freeze at the end of the dose. So as the Parkinson disease progresses, you find that one dosing of Cinemet, 1 tablet 3 times a day, is no longer effective, because they start to freeze before everything shuts down. There's motor freezing and everything, they shut down before the next dose. And so what you start to have to do is try to bring the doses closer together to cover that period of freezing. The drug takes about half an hour to start working, so you have to give time of overlap. So if the freezing is happening 3 hours after the last dose, then you have to pull the doses together so that you start the next dose maybe 2.5 hours after the next dose. So you find that you have to give the Cinemet closer and closer together as the disease progresses, because not so much more of the dopaminergic neurons have been lost, and there's not that much left to be stimulated. So you really have to pour on the Cinemet to try to, or these dopamine agonists, to try to get the flog whatever dopaminergic neurons are still left. The pramipexole has the additional benefit of having antidepressant effects. So this is useful because, as I mentioned, Parkinson disease coexists with about 40% of them also suffer from depression. The problem with the dopamine agonists, with the pramipexole and the Requip, is that they could develop compulsive gambling. They could develop hypersexuality. I had a patient who wanted to have sex with his wife all the time, and she couldn't deal with it, you know? And so he would be sneaking out of the house. He could hardly walk. The man is almost on a walker, and go out and looking for prostitutes. And this caused a very big problem with their marriage. They could also have compulsive shopping, somnolence, orthostatic hypotension, and impulse control disorder. So after they've been on these dopamine agonists for 4 years or more, they start to develop anger issues, anxiety, obsessive compulsive disorders that you wouldn't see initially when you first start them on these dopamine agonists. Other agents you could use is the amantadine, which is first brought out to use to treat the flu. But this can cause dopamine release. So it's also helpful for calming down the dyskinesis. So one of the problems in treating with Parkinson's disease is that you want to stop them from having these off phenomena or freezing. But if you increase the dose too much, you end up with dyskinesia. And so they're all wildly swinging all over the place like that. And then 3 hours or 2 hours later, they shut down into the freezing. And so to slow down or to alleviate the dyskinesia, you could add in amantadine to help control all those wild fluctuations. You could also use the extended release form of Sinemet, the Sinemet CR. The problem is that it's not as bioavailability is not the same as the immediate release Sinemet. And so it's only about 60 to 70% bioavailable. So the absorption is more erratic. And so to try to use that during the daytime to eliminate the dyskinesia is not that effective, but we do use it at nighttime because they run out of gas, run out of Sinemet in the middle of the night. They cannot get up to use the restroom to urinate in the middle of the night. So you have to use the extended release at bedtime to carry them through till morning. You may also start with monoamine oxidase type B inhibitors like selegiline and rasalgiline. These agents are more milder agents. There's some reports that selegiline could actually slow down the progression of the disease, and usually 5 milligrams in the morning and 5 milligrams at noon. So you don't give it in the evening, just in the morning and at noon time. But this is, it was challenged by other studies that showed that it didn't really slow down the progression of the Parkinson's disease. And so the verdict is still out on that. One of the better medications to control the tremor is to use the anticholinergic medications, the Artine and the Cogentin. And so the triacetylphenidil and the benztropine, these are useful to help with the resting tremor. They are more effective against the resting tremor than the Sinemet or the dopamine agonists. But you have to be careful when you use them in the elderly because they could if they are borderline dementia, they will tip them right over into dementia. So you have to be careful with these in the elderly. You could also use catecholamine or methyltransferase inhibitors to help prolong the L-DOPA life in the blood. So these inhibit the breakdown of the levodopa. And examples of these are entacapone and tolcapone. The entacapone is only acting extracerebral, so it doesn't cross the blood-brain barrier. But the tolcapone, that goes into the intracerebral compartment as well. So these reduce the off time. They enable the Sinemet to last longer in the patient. But you have to monitor the LFTs with the tolcapone because that can mess with the liver, particularly in the first 3 months of starting the agent. Interestingly enough, they turn the urine orange, so you have to tell the patient that these agents can turn the urine orange. Don't be alarmed about it. Other agents you could use, the antihistamines, the Benadryl maybe help with sleeping. The antihistamines, the amitriptyline has anticholinergic properties with it, so that could help with the tremor as well as the depression. The SSRIs, the most effective one was Zoloft. You could use muscle relaxers, particularly in some Parkinson disease patients, they develop dystonia, especially endose dystonia. So coming toward the end of the dose, the wearing off of the dose, they have dystonia, particularly of the legs. So one foot would start this painful eversion or contortion of one leg. And so baclofen will be helpful in those instances. A lot of patients would have hallucinations. Visual hallucinations are a big problem. Remember one patient who she used to be having this visual hallucination of this big black rabbit sucking on her toe. And she would always be banging her foot trying to kill this big black rabbit. Of course, disturbing the husband all the while from his sleep, because this big black rabbit is sucking on her toe all night. So the husband said, man, woman, just grab a hammer and hit it, man. I'll kill it, you know. He was so fed up. So other peripheral anti-dopaminergic agents you could use is droperidone for the nauseous effect. Interestingly enough, donepezil, which is Aricept, which is a central acetylcholinesterase inhibitor, reduced falls by 50%. So they found that the freezing and the falling was really due to lack of acetylcholine in the brain, because they're not only having the deficiency of dopamine, they have a deficiency of acetylcholine that causes the dementia as well too. And so if you give them the Aricept or similar agent, you also can help reduce the risk of falling by 50%. The other new agent you can use is pimavanserin, which is a 5-HT2A inverse agonist, which significantly reduce psychosis without the side effects of the quetiapine and the Risperdal. Because one of the black box label that will tell you when they're using the quetiapine and the Risperdal is that it could cause patients of early death from cardiovascular cause. But what else you're going to use? They're having so much hallucinations, and how you're going to control these patients is driving the other members of the household up the wall, because they're seeing these other people around the house and at the table. Who is this one? And they start to get very paranoid with the spouse. So they see that next bed with the spouse. There's nobody else. There are 5 people in this bed. What are all these people doing in this bed, you know? And so it's a big problem. As the disease advances, you have these off times, as I mentioned. So the off times is when the body just freezes right up. They cannot move. They're shaking. They're immobile. They're shut right down. So one of the ways to get around this is do a duodenal infusion of levodopa via a peg with a jejunal extension catheter, so that the Sinemet goes directly down into the jejunum, and it's continuous drip, so that they have a smooth, it's like continuous feed of Sinemet, so they don't get the motor fluctuations that happens with end of dose and stuff like that. The problem with this is that the jejunal extension catheter oftentimes get dislodged. They can get perforated intestines, and oftentimes the mechanism of pump stops working, so people get fed up in about a third of the cases. But it does improve the on time by up to 4 hours. It stops those off times. The other agent that they can use is the Zydus selegiline. Now, I mentioned about selegiline before as one of the early agents that you could use, but they have this form that is rapidly absorbed. I just put it in the mouth, and it absorbs in the pregastric absorption it absorbs in the mouth, and so this will help to get rid of their off phenomena when they can't do anything, they can't move, they're all frozen right up. There was a very interesting study came out last week that showed that it was 2 weeks ago, that if you get these patients, but they did it in the early Parkinson disease patients who had the early stages of it, stage 1 and stage 2. If you get them to exercise to 80% of the maximum heart rate about 3 times a week, it actually reversed the disease. And this was very remarkable. We always knew that the best thing for Parkinson's disease, I always tell them for years, is exercise. Exercise is the only thing that's known to slow down this disease, because when you exercise, it causes the release of glial-derived neurotrophic factor, which helps the brain to rebuild itself and stops the degeneration of the brain. But they found that actually it reverses the disease. So when they did the dopamine studies and the SPECT scans, they found that there was more dopamine in the basal ganglia than before they started this exercise program. Other agents you could use to get around, because a lot of them have drooling and salariuria. So you could use botulinum toxin injection in the salivary glands to help control the drooling. They also found that there's a better preparation of the extended-release levodopa called Rytary, which gives a more smoother and sustained action than the Cinemet CR. So this is gives much better and much less off time and end those dyskinesia and all those things that come with that. Of course, you have to deal with the other issues. Parkinson's disease patients, they invariably end up with erectile dysfunction, but it responds very well to Cialis and similar agents. To deal with the orthostatic hypotension, you'll have to use the fludrocortisone, the Florinef, or the midodrine. Midodrine is 5 milligrams 3 times a day, and the fludrocortisone is about 0.1 milligrams. You could also use droxidopa, which is a norepinephrine prodrug that is broken down into norepinephrine. So that can cause vasoconstriction and cause correction of orthostatic hypotension. The problem with the orthostatic hypotension is that you stop the blood pressure from dropping when they're standing, but when they lie down, they have supine hypertension. So that's another thing. You may have to counteract that by giving them a short-acting hypertensive agent at night, probably one of the ACE inhibitors. Some of my patients also, they want to do a herbal. They want to go herbal. So there is a preparation called mucuna dopa that's extract from a plant in India. And so that has natural levodopa in it, so they can use that as well. If other effective treatment is like dance therapy, aerobic activity, as I say, exercise is the key to slowing this disease down. Also, vitamin B12 and vitamin D3 level are often low in these individuals, so replacing that also could improve their outcome. And I mentioned before, avoid insecticide use. If all else fail, there are surgical interventions that you could use. Thalamotomy, they used to be using, there's no longer use because they have a better way now called thalamic stimulation. They get similar results from the similar results to thalamotomy, but you don't have to damage the brain. You just put that stimulation probe. There's a risk, of course, of hemorrhage, of stroke formation, infection as well. But it's not like you destroying the part of the brain. So they tend to go for the subthalamic nucleus stimulation and the medial aspect of the global pallidus. Human fetal transplantation, the grafts did work. They did produce dopamine, but it caused, in some people, intolerable dyskinesis. So it really didn't cause any improved outcome, at least not yet. And same with nerve growth factor implants, no success as well. They are now using MR-guided focused ultrasound ablation of the subthalamic nucleus and the medial globus pallidus or thalamus. So this is like doing a thalamotomy, like what they used to do, but they don't open the brain anymore. So they put the patient in an MRI machine, they put a big old water buckets, as it was, strapped around the head, and they focus a very focused ultrasound beam under MRI guidance directly into the subthalamic nucleus to damage that nucleus, to shut down the tremor and shut down improve the hypokinesis and other features of Parkinson's disease. Now, we come to the interesting part, gut microbiome. It has been discovered that a few years ago that when they looked at the feces, they gave the feces of Parkinson's disease patients to rats, and they also fed them the feces of normal persons, and they found that the rats who got the feces of Parkinson's patients developed Parkinson's disease. They said, what is this? So they looked and said, what is inside these feces from the Parkinson's patients that was giving them Parkinson's disease? And lo and behold, they found that there was a decrease in beneficial bacteria. And the decrease in beneficial bacteria was decreased by up to 60%. The gut microbiome, there are supposed to be 1,000 different species in the colon in normal people. But in Parkinson's disease, it's reduced down to 60%. This is also seen in multiple sclerosis and other diseases as well. And what they found, interestingly, is that they found what was killing off the good microbiome was a bacteriophage, which you got from cow's milk. So this bacteriophage, which is a very large virus, was killing off the beneficial bacteria and causing overgrowth of 2 other species called desulfovibrio and Clostridium perfringens. And what they discovered that these 2 agents, this was a recent discovery in the last 6 months, that they were elaborating toxins that were being absorbed retroaxonally by the vagus nerve. So the vagus nerve, they distributed. I mean, it innervates all the gut, and so it was theorized that these toxins elaborated by the desulfovibrio and Clostridium perfringens were being absorbed by the vagus nerve and taken straight up to the through the midbrain with a substantia nigra, and was causing the damage to the substantia nigra. Researchers in Sweden, therefore, they did start doing vagotomies. So they cut the vagus nerve and see if that will stop the progression of the Parkinson's disease. Unfortunately, it didn't do so, but they're theorizing maybe if it was cut earlier, it might cause it, but nobody has figured that out. So what I've been starting to do is that the treatment for these sulfovibrio clostridium perfringens is to use a simple cocktail of minocycline 100 milligrams twice a day and flagyl 500 milligrams 3 times a day for 10 days to try to eradicate them from the gut. And I found some interesting improvement in some of the patients. So when I get enough, I'm going to write up and try to see how this works. I mean, see what type of results I get. But at least I know at least one patient who had some noticeable improvement. The other thing that they're doing is fecal transplant. Now, we were doing that here before the pandemic. We were doing it out by Doctor's Hospital, out by Blake Road. We would have people come in and we would have the fecal bacteria from healthy donors extracted, and they would implant them in the rectally after doing a colonic washout. They would implant them using a rectal tube. But recently, in the last week, a study came out that shows that if they give the fecal, they did a double-blind fecal transplant study where they got feces from regular persons. Either they use their own feces or they use feces from a healthy donor, and they infuse them directly into the duodenum. So the person didn't know if they were getting their own feces or was getting a donated feces to be put into the duodenum. And what they found that at 9 to 12 months, there was significant decline. So there was loss of progression. You could see a noticeable difference between those who got the fecal transplant from healthy donors versus those who got the fecal transplant from their own feces. And those who got it from the healthy donors, but it took about 6 to 9 months to see the difference, to see that they had significant improvement in their Parkinson's disease. So this is an area of very interesting research now that is now being done. And I hope I didn't take up too much of your time, but anybody would have any questions about my presentation this morning?
Thank you so much, Dr. Raming. That was quite a comprehensive presentation.
Thank you.
Certainly packed a lot of good information inside there. It was very exciting to listen to the presentation, get all of that wonderful information, and you truly brought the presentation alive, I must say. I absolutely loved your passion as you spoke about this topic, and you truly kept me engaged from beginning to end. So thank you so much for that. We will now open up the chat for comments, questions, and we have some coming in already. We have Dr. Frank. Hi, Dr. Frankson. Dr. Frankson has several articles from NIH, among others, are linking infectious agents, including particular fungi, to infestation around substantia nigra, etc., in brain histology of Parkinson's disease patients. Has these research findings started to influence the prevention and treatment of Parkinson's disease?
Well, I've seen that being mentioned with Alzheimer's, but not so much with Parkinson's disease, with the fungi, with the Candida species being incriminated in Alzheimer's disease. Um, I I always put all my patients on probiotics. There's some people who believe that because when you give the probiotics, they go into a spore form in the stomach when they hit the stomach acid. And so it'd probably be better if it was to be given rectally, you know? And so, but then you'll need a rectal tube to do that, dissolve the probiotic and give it up into the rectum to try replenish all of the missing bacteria that 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 you had, you know. Hello?
Yes, we're here.
Okay, so I didn't know my screen went blank. So
Yes, I noticed Dr. Raming quite a few articles. I've been following them with interest. Even the one that is pointed the finger for shifting clouds, we call them in the Bahamas, that those facial fungi, Malassezia furfur, and so forth, and also certain Candida species and and molds. Some of the articles I'm mentioning coming out of NIH, so that's why I raised the issue.
Yes. Those is becoming increasingly aware that these agents in our environment are not as benign as we think they are, you know, and we are being attacked by these microbes all the day long. It is well known that disease like Alzheimer's disease, they progress with they deteriorate with every common cold that you get, every flu that you get, they have a new baseline. And so these agents are relentlessly attacking us. We're not even aware. So one day, you know, they might find a way to make sure we don't never get any common cold or the flu or COVID-19 or whatever, because all these agents, they leave us with damage that accrue over time. You see?
Hey, Charles.
Thank you.
Morning, Charles.
Morning.
This Prof. Ekidili. Yeah.
Yes.
Wonderful presentation, actually.
Thank you.
Just want to make some comments. Number one, like you said, we don't do soft thalalectomy or thalalectomy. I used to do them.
Right.
Embryonic implantation, stem cell, is a form of stem cell, autologous. But you know what happened with that, with, embryonic, whether you're allowed to do it or not. It has prospects, but the problem with that is the religious and everything around it. It hasn't been proven, it hasn't given us much, a lot of success that we expected because of so much controversies. But now what I want to point out is deep brain stimulation. That's what we're doing now.
Yeah, that's what they're doing now.
Yeah, the deep brain stimulation, I want to introduce it here because of so much issues. Couldn't even do the simple surgeries. You can imagine deep brain stimulation, which is actually simpler. It's a borehole and put the probes in them, and it resolves a lot. A couple of prominent people in the US, have Parkinson. That's what they do, and it resolves like 5 years, but they go back. You have to, because the process continues. It's a degenerative disease. You tend to have back the bradykinesia, etc., etc. You might have to do it twice. But what we do right now is to put that probe, and sometimes you set it up with a battery, so that if your symptoms start to come back, you tune it again, tends to brush it away. But it's just a very important technique. A lot of prospects with deep brain stimulation.
Yeah, and the thing about deep brain stimulation, you could do it bilaterally. With with the ablation, you never could do it bilaterally. You only get out to do it unilaterally. But with the deep brain stimulation, you could hit the two subthalamic nucleus or the two medial globus pallidus or whatever your target. They're also targeting now. They find with deep brain stimulation, the best target is the ponto is the
at the end, what you do,
the cerebropontine angle there. That nucleus there, cerebropontine nucleus, that one is what they're targeting now as the more preferred site for the stimulation.
Yeah, it depends where the ass, the long ass, wherever the symptoms is more prominent.
Right.
Like you said, it could be hemi-Parkinson, or it could be bilateral Parkinson. So,
right.
So that's an interesting topic, and any of your family members, guys, they, at least for now, medical treatment, which Dr. Rami has very nicely put forward. But that's my comment. Congratulations, just a nice work. Okay.
Yeah, thank you.
Okay.
So I also put all my patients on the probiotics, the coconut oil. I failed to mention the coconut oil. I give them all that because that helps with the tremor. Okay, so coconut oil has an effect on the tremor, resting tremor. So they all get the coconut oil, get the probiotics, omega-3 fish oil to stop the brain deteriorating. And of course, they have to avoid all of the agents. They can be using off or any type of insecticide on the skin and spraying all those insecticides around the place.
Okay, thank you. Thank you for that. We have more comments inside the chat. Awesome. Thank you, Dr. Rami. It's from Dr. LaVille. Dr. Hannah is asking about if you've used or would you recommend probiotics and if there was any improvement.
Absolutely. I can't say that I can see any improvement, but I give it from the theoretical point of view. As I mentioned before, the probiotics, most of it is turned into a spore form when it hits the gastric acid. So they say a lot of it is just passed out in the feces. The way you get around it, you have to use a rectal probe and implant it rectally. Some people go to that extreme, but not many.
Okay, thank you for that. Mackenzie, excellent presentation. Dr. Griffith Bowe is very concerned about the pesticide linkage, which is very commonly used, including in household items. And she's asking any guidance about how much use is too much.
I don't use insecticide in my house at all. If I have to use insecticide, I spray it on the outside of my doors. And that would be every probably 4 to 6 months. So if you have a problem with roaches or whatever coming in, or ants, just use the ants bait, the Teros ants bait, okay? So the liquid ant bait, that'll get rid of the ants. For the roaches, make a barrier. Go outside your door or the garage or wherever you have and spray a barrier outside. Don't breathe that stuff inside your house. Never come and spray the baseboard of your house, okay? Because you're going to breathe that stuff in and it's harmful to your brain. Okay, you might not see it now, but it catch up with you in a couple of decades.
Absolutely. We have another message. Great presentation, very useful information and benefits for the use of probiotics. Oh, any benefits of the use of probiotics in eradicating the invasive bacteria in the gut? I think we had a similar question a little bit earlier. And Dr. Belgrave King, excellent presentation. Thanks for the insightful information and wealth of knowledge and experience shared. Dr. Zonapol Newton, very informative and stimulating presentation. Thank you, Dr. Rami. Dr. Roka Davis, very informative. Thank you. So as you see, Dr. Rami, presentation well attended, and many are very appreciative of your shared expertise on this subject matter. Just before we leave, I just want to remind everyone to please complete your feedback. You had lots of wonderful comments to say. Let's document them and put them in black and white. And also to remind you about our next upcoming CME, which will be on the 26th of this month. That is the last Friday. We will be discussing important protocols and procedure as it relates to you getting that very wonderful, precious gift of blood to your patients. So look out for that. So again, Dr. Raming, thank you so very much. And we look forward to having you again to give us your expertise on other subject matter in your area of specialty. Thank you all for attending our very informative CME. You have just leveled up in your knowledge, and we hope to see you at our next CME, April 26th at 8 o'clock a.m. Have a good day.